Well, welcome to the Bridge2AI open house. So this is our second open house for the consortium. It's great to see many of you here, and those of you who are joining us online, it's good to have you. First of all, I'd like to sort of say it was great seeing a lot of people at the poster presentations yesterday. It was a great turnout. I was really happy to sort of see all those posters, the students there, all the investigators interacting. It was a great evening. So we're going to kick this off with updates from the different grand challenges with respect to where they are now, right, with respect to the data releases. So obviously, a lot of work has happened in the past year, and we want to sort of give everyone an opportunity to hear what they've been doing, both in terms of what the data looks like, as well as the activities that have been surrounding it. So I'm going to ask each of the presenters to just briefly introduce themselves as they come up.
Good morning, everyone. Just raise of hand, who was not here the last 2 days? Perfect. Welcome. For the others, there's going to be a little bit of repetition, but we did reorganize our talk, so it's going to be great. Let's see if that works. So I'm the contact PI of the Voice DGP, Voice as a Biomarker of Health. And we will play a little video that was made with patients and partners to explain what we do.
Did you know your voice can tell a lot about your health? You've probably heard the phrase, "you sound sick," or "you sound tired." That's because even subtle changes in your body can affect the way you sound and could be early signs of various diseases, such as Parkinson's disease, mood disorders, and some cancers. These changes can be undetectable to the human ear, but could be spotted earlier than ever with artificial intelligence. And to make these AI tools effective, we need to train them on data. A lot of data. The goal of Bridge2AI Voice is to create a large, accessible database of diverse voices, speech, and breathing sounds, to advance voice AI research, and create new tools to assist in disease screening, diagnosis, and treatment. This will help improve human health around the world and will guide the ethical use of voice AI in healthcare. We just need your help. So if you'd like your voice to fuel voice AI research or would like to learn more, visit b2ai-voice.org.
So our aims and goals are to build an ethically sourced, diverse, and AI-ready database of human voices linked to health information from 5 categories of diseases. We go from neurological disorders, mood disorders, pediatric disorders, voice disorders, and respiratory and cardiorespiratory disorders. And now we're actually collecting for normal patients with all kinds of other diseases as well. And then we're also going to focus on our other aims and goals. One, creating a network of stakeholders, building standards, building best practices to build the tech infrastructure to collect that data, the ethical guidelines, and how to teach and train the next generation. So if we look into the data types we collect 22 bioacoustic tasks per patient. So that's a lot of speech, voice, and respiration. We collect tons of demographics because we know that it has an impact on the voice. We collect confounders, smoking history, drugs and alcohol, and even fatigue and hydration. We collect some genomic data for our neurological cohort. And one of the most important ones are validated questionnaires, what we call PROs. They're patients reported instead of clinicians reported, and that can become the gold truth for annotation and labeling of the data. And we also collect imaging through EHR. How do we collect the data? We collect using a iPad with an app that was specifically developed for our project called the Bridge2AI Voice app. So you can see how this patient is collecting the voice. These are our data collection protocols. So within our 22 acoustic tasks, it was really important for us to have non-voice, non-speech tasks, so respiration, cough, then voice tasks, glides, and then speech tasks, because it really captures all the areas from respiration to cognition. And when you have other studies that we're going to talk about that have certain tasks, you can also compare these studies with ours. There's also clinical validation data. So each patient sees a provider. The provider will input the diagnosis and the specifics of the diagnosis. So all the data is annotated accurately. We published our protocols at Interspeech, which is the kind of biggest speech conference, an international speech conference. So those protocols are now available, and they were produced by consensus of expert. It actually took 6 months to bring all the different experts in the different diseases to come together and look at which were the best tasks, the best validated questionnaires for each disease. We're very excited to have produced our dataset V2 that was released about 2 months ago, and it is available on PhysioNet. So this is more than 16,000 recordings from 442 participants. You could see on the demographics, they're pretty well spread between voice, mood disorder, respiratory, and neuro disorders. If you haven't, you can look on PhysioNet and download the data. This is our low-tier data set, so it does not contain raw voice data yet, but it contains transforms like spectrograms, acoustic tasks, so you only need registered access. You don't need a DUA to access it. It's readily accessible. Preliminary impact has been great. We've had a lot of downloads, more than 40 datasets download that were outside of our project since January. More than 50 downloads from people attending our hackathons and our training sessions. We already have multiple requests saying, when is the raw data coming? And that has to do with ethics. So we're hoping to have that released in the next couple of months. Lots of presentation at international conferences. And we've learned that the best ever way to know if your data is useful is to host hackathons, training sessions, because this is really how you test if your data is used from a clinical standpoint and AI ready for engineers to be able to hack. So now going over the best practices we've developed, if you remember my first slide, the first one was community building and networking. And we've actually learned that the best way to do this was through a yearly event called the Voice AI Symposium. We kind of stumbled into it. We didn't plan when we wrote this grant to build a conference, but when we had the press release of the Bridge2AI, I started getting emails. I had about 100 emails a day in my mailbox, and I would say maybe 25 of those were linked to Bridge2AI. People saying, we want to participate. How can we participate? And we had no idea. We had just started. So my great PO and scientist back then said, why don't you host a conference? So now whenever somebody says, we want to collaborate, how can we collaborate? I say, well, why don't you come to our conference? And it's the third year. We've had 200 people this year. It's become international. We have people from all over the world coming, academic, startup industry, and very huge impact. So much that now we have more than 1,000 followers on LinkedIn. People repost, and that's really important to get. Thank you. To get the community to participate in what you do at Bridge2AI, our goal is to create a resource for the community and get feedback. And the best way to get feedback is get the word out there. And we've been successful at doing that. In terms of publications, we also work with Frontiers of Digital Health. We have a special issue. So not only do we publish, but other people can publish about voice biomarkers in that special issue. In terms of standards developed, so we developed acoustic standards in the lab to see what are the best ways to capture voice data that is scalable and not expensive. So this was published in multiple journals, and our team concluded, led by Shaheen Awan and Ruth Barr, who's here, that the best way was with an iPad and a headset to control microphone distance. And now we will do some remote piloting at home and compare the quality of the data from the lab into the home. AI readiness tools and standards were also developed by Satra Ghosh and his team at MIT, all open source. So that helps you pre-process the data, analyze the data, extract spectrograms automatically. I have to go a little fast. All of it is available on GitHub. We've also built a harmonization tool. So this is a Bridge2AI voice repository tool that captures all the different voice repositories before ours. So there's about 300, and you could look at what type of data they contain, what type of access you need, what type of diseases. So that's a really great tool for harmonizations of data set. Technology. So the app was developed by Alex Higueras at Cornell, and you can see there that basically the backend infrastructure captures different sites and brings together different sites of data acquisition. You can do gain control, you can consent, diagnose, and select tasks in the app. That was published also in Frontiers of Digital Health in terms of initial feasibility study to acquire data through mobile health, which is really important. A lot of our patients are old, and to do that feasibility study was key to understand how they would interact with the technology. This is our data dashboard, which is public facing, so you can see all the types of data and patients that we have. Almost last, ethics. So best practices in ethics, that was actually the hardest part of our job. And I always say if it were easy, everybody would do it. But I think we've had about 59 amendments to our protocol, and it's probably a small number compared to the reality. We've had to go back and reconsent some people. So extremely important lessons learned doing this. And if you have trouble with your IRBs or consents and you want to hear about what mistakes we did, please come and talk to us. It's been really interesting. All of that because HIPAA could be, because voice could be considered as a HIPAA identifier by some universities versus some do not and think it's only admissible under the common rule, which is really interesting. So we've actually determined that raw voice is not protected under HIPAA, but should be under the common rule considered sensitive information. That work was done with a lot of lawyers, general counsel, actually evidence-based experiments trying to re-identify people. And because of that, our data governance is in 2 tiers. Here you see 3. One tier is basically sharing between our teams and our data collectors. And the first team is registered access, so where you can get the non-raw data with data transforms, and then controlled access for raw voice data. So if you want to access our raw voice data set to protect patients' privacy, it has to be with a DUA within your institution. Do I have 1 more minute? No, okay. Okay. This is our Bridge2AI Voice Atlas, where you can learn about the different data governance structures of different data sets across the world in North America. This is our memorandum that we published, so why we thought that voice should be considered under common rule. And that's really important to explain kind of our lessons learned within the community. We don't want to call it best practices because there's no law or legislation around it yet, but explaining why we think voice should be considered as sensitive information. And lastly, training the future. So we've had hackathons and summer schools, extremely successful. People are very happy. They've said it's the best experience they've had because there was really no curriculum for voice AI that was happening. And our goal was to do something multidisciplinary. So we brought medical school students together with engineerings, and the collaboration and the multidisciplinary collaboration really made an impact in terms of how impactful the results were from the challenges. We have a website called Bridge2AI Scholars, Voice Scholars, if you want to hire these people that are now very well versed in voice AI. They are fantastic scholars. This is a picture of engineers in the OR. If we have had a few faint actually in my OR and in my clinic, so don't bring engineers to the OR. That's what we've learned. And that's it. Thank you so much.